the afternoon session had better been short, so that you go and burn out some of what you've taken. Okay, so we stopped with AI and digital session, digitalization and digital issues. So we're now moving to the next. I was told that the Secretary General was not available in the morning. Is not yet here. So that presentation for now is on hold. So we shall have 1, 2, 3, 4 presentations this afternoon. All of them are really dealing with workforce. So we shall run through all the 4. Then we have a session for questions and answers. And again, as we did in the morning, after every session, before you forget, write your question, write your comment immediately, and hand over to the assistants to send to the person you are sending to. So may I take the honor now to invite the following to the front. Sikanyiso Sengwayo, Mr. If I can hazard, Mr. or Doctor, let's say Doctor. Yes, please take a seat. You're welcome. He's from Eswatini, he's our host. Next, Dr. Innocent Besije. This one must be from Uganda. Welcome him with an applause. Please welcome Dr. Innocent Besije. You'll get to know what is good. That's in the program anyway. Then we have Professor David O. Okello from Uganda. Welcome. And he works with a chest. Then Joseph Kariuki, Senior Program Manager, Eastern Southern Smile Train. A namesake, I think, is coming back. We're together in the morning. Yeah, those are the 4 presentations that we shall have. And then we do the discussions. Okay, so without wasting any more time, let me invite Sengwano. Sengwano is the National Quality Technical Manager, Minister of Health, Eswatini, and he's going to take us through the topic, Youth at the Center, Unlocking Africa's Demographic Dividend. Welcome, Doc. He looks youth. You're welcome. Please give him a applause. Thank you. Mike is there. 10 minutes.
Thank you very much, Program Director. I really look cute when I'm standing next to you. So my name, or maybe let me start by observing the protocol that has already been established and say good afternoon to everyone. My name is Sikanyiso Sengwayo. I know it's difficult to pronounce the first name, but it's easier for those that are in the country. They know why. And then I work for the Ministry of Health, as already been alluded to. Today I stand before you to talk about our journey as the youth of the ECSA region, if I may put it that way. It's our journey of actually positioning our youth at the center towards unlocking Africa's demographic dividend. That is what we are going to be, what I'm going to be talking about today. So, and I will start the discussion with what is already known, or what you are familiar with, a number that you are already familiar with, which is that about 60% of Africa's population is under the age of 25 years. That is well known. And that places us at a potential demographic dividend. And, but I'm saying potential demographic dividend. For us to be able to reach the actual demographic dividend, there needs to be investments that are done on the youth. And so for every forward-looking society, we need to invest towards the youth to ensure that we reach the actual demographic dividend. There are some global and regional frameworks that have been developed that are talking about investing on young people. Some of these, they include the 2030 Agenda for Sustainable Development, Agenda 2063, the African Youth Charter, the AU Roadmap on harnessing the demographic dividend through investments in youth. And I will finally talk about our own resolutions that have been made by our ECSA health ministers, which are adopting several resolutions to promote adolescents and youth health. I'm mentioning these frameworks intentionally because at the very core of these frameworks, this is where we have made them the foundation of actually developing our model for youth engagement in the ECSA region. And so that's where, that is what we will be talking about today, how we have actually worked with our youth to ensure that, how we have put our youth at the center of everything to actually unlock Africa's demographic dividend. So the objectives of this intervention, putting the youth at the center of everything, is that we want to actually position our youth as leaders and strengthen youth engagement in the ECSA region. And secondly, we want to bridge the gap between policymakers and the youth by promoting evidence-based youth-led solutions, as well as to expand access to youth-friendly services, especially underserved communities and the youth with disabilities. And finally, we are looking at institutionalizing meaningful youth participation in governance and decision-making structures. So we are going, as I go through what we have done in the period that we are reporting about, you are going to be able to appreciate how we are meeting some or all of these objectives. And I started the presentation with a picture, and here comes the picture again. The reason why this photo is coming up again is because for us as young people in the region, it really is, it resembles a turning point in terms of youth engagement in the ECSA region. This was the ECSA Regional Youth Summit that was held in Eswatini in January 2026, the first of its kind. And the reason why we are saying that it's a milestone for our youth in the region is because we felt that for the very first time, the youth has moved beyond being consulted. We're actually part of the policy discussions and dictating what policy should look like for the youth in the coming years. And so the theme was unlocking Africa's future, harnessing the demographic dividend through integrated sexual and reproductive health investments. The biggest outcomes that we saw from this Regional Youth Summit is that we saw an amplification of the voice of the youth, whereby we are saying our youth moved from being consulted to actually sitting at the table and discussing issues and how we can actually sustain interventions that are targeting the youth. It was also an opportunity where we were able to develop networks and collective action commitments. And the collective action commitments, this is where our model is built upon. You would find that in the past we would have, you would have meetings and all those things, but this time around we are saying, if there are commitments that have been made, can the youth lead from the front to follow up on those commitments? And so that is why we are saying we developed this model. So as a follow-up from the ECSA Regional Youth Summit, we then had national interministerial dialogues. These national interministerial dialogues, as I've already said, are building up on the commitments that were made during the Regional Youth Summit. the intent, or let me just say, with the ones that we have been able to hold, the interministerial dialogues that we have been able to hold in Uganda and Lesotho, we were able to bring together policymakers, leaders in the different countries, the youth as well as partners. And they were able actually to sit down and look into the commitments that were made during the Regional Youth Summit. And then we were trying to operationalize that at country level, because the context, we may have similar problems, but the context, it gets to be different as you drill down to the different countries. And so that is why we are now holding the National Interministerial Dialogues. We have been able to hold this in Uganda and Lesotho, and what we are seeing as an outcome is that youth participation, combined with strategic investments in SRH, education, economic empowerment, inclusion and leadership is very critical for us in unlocking the demographic dividend. So what we are now asking is that we might have done it in these two countries. To scale it up, we have to be able to do it in other countries in the region. The reason for this, it is able to actually inform policy as we go forward. Then under digital advocacy, there is a feature of our model that talks to digital advocacy. We have actually been able to organize regional webinars and in-country webinars. The only regional webinar that we have conducted so far, we have conducted one, and then again, we conducted in-country webinars in Lesotho and Uganda. I hope we are learning from Lesotho and Uganda. They are really leading, and we hope that we will get some indulgence with other countries as we go forward again. So what we learned with these regional and national webinars is that it has been able to sustain youth engagement, and it actually addresses the gaps of physical interactions. We are able to reach a wider audience with our digital advocacy mechanisms. It has also been found, we have found that it is very cost effective and expands the reach of our program. It has strengthened accountability, and we have got planned webinars that are coming for Eswatini and Zimbabwe. These are the ones that are imminently coming, but our plan is that we have to scale it through the entire region. And then as part of still our digital advocacy, we have been able to set up a strategy on social media engagement. This is the youth that we are dealing with, and the youth, they have needed a space where their voices could be seen, they could be heard, and they could be connected. And so we started creating these spaces for them. In terms of what we did, how we exactly did it, we create content because this is something that we continuously do. We create content, we promote webinars, and we share youth stories using the known social media platforms, including WhatsApp, TikTok, and Instagram. And again, it increases the visibility of our interventions in the region, and there is now stronger youth engagement. So in terms of what we have achieved so far, because this platform...
In 2 minutes.
So I have 2 minutes, I will just brush through, thank you, Chair. So in terms of what we have achieved, so far we have had views growing from 0 to above 185,000. This is something that we created from scratch. It wasn't there before. Then we have established ECSA's, our ECSA Commonwealth Climate Health Youth Initiative. And I will not drill much on what we did here, but basically we are saying that these are partnerships that we need to bank on. We are fostering some partnerships as the youth, and these partnerships are led by the youth in the region, in the ECSA region. And then we also, in terms of these partnerships, we were able to also work in co-designing our landmark policy on regional mental health framework. So we are also then implementing this, and it talks to issues around governance and leadership on issues of mental health in the region, how we can actually harness youth-friendly services, and as well as looking at how we can strengthen the existing partnerships that we have. Now, I pause a little bit because, like I said, we want to really strengthen this going forward. We want to institutionalize these interventions. And I present to you what is upcoming for the youth in terms of our upcoming activities. We have got the Regional Youth Dermatology Summit in 2027 that we are planning to conduct as a youth. And so we are really pleading with member states to actually partner with us in this journey and help us to empower the next generation of dermatology leaders and strengthen youth leadership in skin health across the ECSA region, as well as to help us to foster innovation, research, and mentorship in dermatology. We will always share more details around this one, but we are really looking forward to how you can actually support this initiative as we go forward. As I conclude, the youth is saying that the future of East, Central, and Southern Africa is not walking into this room tomorrow. It is standing with us here today, and we just need to harness it. And the youth is also saying that we are saying there is nothing for the youth without the youth. And as we are going along this, the youth is saying, please walk with us, please work with us, please partner with us as we build the Africa we want. Thank you.
Thank you very much. Thank you. Thank you for the efforts to unlock the Africa's demographic dividend. Okay, so let's go to the second presentation by Dr. Innocent Besige. Human Resources for Health, overview of ECSA and the role of constituent colleges in health workforce development. You have 10 minutes.
Thank you so much, moderator. Allow me in the interest of time to ride on the already established protocol, but I think it is important that I also introduce myself. My name is Innocent Besige. I'm a family physician and I work at Makerere University in Kampala, Uganda, as a senior lecturer and head of the Department of Family Medicine in the College of Health Sciences. But I'm here as the president of the ECSA College of Family Physicians, which is one of the constituent colleges of the ECSA College of Health Sciences. But I'm speaking on behalf of the Senate of the ECSA College of Health Sciences, which is composed of college presidents and secretary generals. So therefore, when you are forwarding your questions, please address them to Senate. Don't address them to me, so that they are appropriately addressed. Can I have my presentation up, please? Okay. Yeah, so I will be talking about human resources for health, but I will first give you an overview of what ECSA College of Health Sciences is and the role of the constituent colleges in the workforce, health workforce development in our region. About ECSA-CHS, the East Central and Southern Africa College of Health Sciences is a coordinating college for the ECSA affiliated professional colleges, and it was established by the ECSA Health Community member states in 2014 under the Health Ministers Conference Resolution 8, and it reads as implementation of the roadmap for scaling up the human resources for health in the African region. Now, why the college model matters? Because I know many of you here in this room, you are quite familiar with specialist training of medical workers that is university-based. But the ECSA College of Health Sciences, the ECSA Health Community member states, they recognized the persistent and specialist shortages. And I think if you have been listening since morning, we are still echoing the same problem. With high cost of training, and you know that the beginning of specialist medical training was actually happening mainly in Europe, and also inequitable distribution of expertise. Most of the specialists are in urban centers and the cities. So the ex-health community formed the colleges to address human resources for health situation in the region. And I think the very first college to be formed was the ECSA-HC, the College of Nursing, which was 30 years ago. And by 2024, the ECSA College of Health Sciences has a total of 11 constituent colleges. Now, the collegiate model is a college without walls, so you don't look for buildings of these colleges. But we deliver specialist training through a network of accredited institutions across member countries, and we use harmonized curricula, common examinations, and shared quality assurance under the unified governance framework. Now, as I mentioned in the beginning, traditionally, specialist training was done in universities. So the collegiate model complements university training, and this is done through regionally relevant, competent-based postgraduate education, and it is embedded in the service delivery. So we basically focus on workplace-based training and assessment. And briefly, that is how the model works. We have the regional curriculum. So the curriculum is first approved at the ECSA-CHS level, which is based with headquarters in Arusha. And then after the curriculum is approved, then we accredit training sites in the different countries. And of course, the accreditation follows validated checklists, and the training is supervised. So wherever the training, before a training site is accredited, we must first establish that the relevant specialists are present. And then we do an assessment to ensure that the specialist graduate who is being awarded the fellowship has the required competencies. And of course, we have, in a way, sort of the thorn in the flesh, which has been retention. When the people train, they move to other countries for greener pastures, but the experience from the collegiate training model is that we have really a lot of retention. For example, the surgeons, more than 93% of them have remained working in the region. Now, having given you an overview of the ECSA College of Health Sciences, I now want to talk about the constituent colleges. As I mentioned, we so far have 11 constituent colleges, including the College of Surgeons, College of Physicians, College of Obstetricians, College of Nursing and Midwifery, College of Ophthalmology, the College of Anesthesiologists, we have the one of Pathologists, the one of Pediatricians, Family Physicians, and the College of Public Health Physicians. But others are coming in. We have in a pipeline more than 3. As you notice that there are quite a number of specialists who are not yet having the colleges. So for example, we have applications from the College of Psychiatrists, the College of Pharmacists is also coming, and the College of Dental Medicine. Now, the role of the college in the health workforce is basically to set competence-based standards for specialist education, accredit training sites and safeguard quality, then you train, mentor, and assess the next generation of specialists, and to establish credible specialist career pathways, because within these different specialists, there are also sub-specialties in there. And then also to advance research, guidelines, and service improvement. And finally, to link member countries through professional collaboration. So, why would one invest in the collegiate model? As I mentioned before, university-based training models are quite limited. So you have a maximum intake, but for colleges, we actually, because the college without walls, you can easily scale up. And it delivers specialist training through the College Without Walls network embedded in accredited hospitals. And to reduce it reduces dependence on overseas specialist training, builds and retains specialists where they are most needed. And as I've mentioned, experience shows that because people train within their places of work, they tend to stay there, but with better skills and better knowledge. And therefore, finally, it strengthens service delivery while training the workforce. I just want to give you a snapshot. So far, some of the achievements of the regional workforce reported results. We so far have 216 training sites across different countries. And in the training now, we have over 1,460 trainees distributed among different colleges, and we have 1,011 trainers. So you see, we really focus a lot on the training of clinical trainers. And 141 master trainers. And I want to give you this, as you know that the College of Surgeons is one of the oldest. It has so far had 1,183 graduates. And as I mentioned, more than 93% of these specialists have actually remained working in our different countries and areas. Now, what is the value proposition that we are putting forward for the ministries of health? Number one is that quality training is actually cost effective, and it is able to harmonize the standards, and the qualifications are recognized across the ECSA region. And it strengthens referral hospitals and teaching capacity because you have specialists present where they are most needed. And then, of course, regional collaboration and workforce mobility. And this mobility basically refers to the mobility within the ECSA region. And then finally, it supports universal health coverage and health security, which everyone is really looking towards achieving. So finally, really the case for scale-up of college training, we need to expand the colleges into additional specialties. Like I mentioned, when you know it's only 11 colleges, but we know there are several other medical specialties which are really relevant. For example, we don't have a college of radiologists. So we really feel that we should expand into other additional specialties, and also increase scholarships and national funding. And for those who are from government, please, when you go back, the ECSA College of Health Sciences cannot survive on tuition paid by the trainees. We really need government support in addition to any other sources of funding. And of course, we need to strengthen accreditation and recognition. Accreditation in some countries is a bit problematic, so we need the support from the ministries of health. And of course, we also need to invest in digital learning and faculty development, because these are colleges without walls. So we don't have classrooms, lecture rooms, and therefore we heavily rely on digital platforms, and we really need the support to be able to achieve this. And finally, we really need to monitor workforce outcomes and impact so that we can continue building the case for the collegiate model of training. Thank you so much for listening to me.
Thank you very much, Dr. Innocent. I think that's very, very important information. And I believe many people in the room have benefited from this enlightenment. College model is a college without walls. I think that is a good information for us. Thank you very much. Let's move on. Next, we have Professor David Okello, the ED of ACHEST, Kampala, Uganda. Is going to talk about advancing the health workforce investment agenda in Africa. You're welcome.
Thank you,
10 minutes.
moderator. Sanibonani bongozi. Njani. I have to say that I learned that language 20 years ago. I am now forgetting. But please continue teasing me so that I can recall. Okay, let's have my slides, please. I'm also going to be talking about the health personnel that we use. This is a very important subject for our discussion. The health workers are the engine of the health system. And the more we learn about it, the more we exchange ideas on how to expand them, how to use them, I think it's better. So you will hear from me. The work I'm going to present today is work we are doing collaboratively between the African Center for Global Health and Social Transformation, ACHEST, and WHO Afro Health Workforce Unit. This is perhaps the first time you are listening to it, but most of the information I'm giving you today is online. You can go online and extract the key messages. It's available, really. Now, let me give you the background. I think you all know we are still having a health workforce crisis in Africa. As we speak now, we estimate about 6 million health workforce deficit in Africa, compounded by a number of problems, including inadequate distribution of the workforce. Also, nearly 1 million of the health workforce we have trained are, unfortunately, are not employed. So we are talking about training. Yes, we need to train more, but we should train people we can use. There are many people on the streets. You may not know this, but there are people who have been trained who are not working. And it's a crisis for all of us. If we invest in training, we must use what we have trained. Because there's rising demand. There's demand for UHC, there's demand for health security, and so on and so forth. So I'm going to talk about this point at length. Fortunately, there is some commitment from our ministers of health. In 2012, they made a decision to write a proposal on regional roadmap for scaling up human resources for improved health service delivery. This is available online. There is also some renewed commitment that was made later in 2017, again talking about the issue of human resources for health. Strategic focus framework called for adequate, sustained investment to ensure equitable distribution and quality of health workforce. And there's been good progress across the region in the past, since 2017. There's also a global context to all this. I think at the global level, there is a changing demographics. All of you come from countries where you know the population is living longer, we have more people, and so we need more professionals dealing with health care. But there's also a growing burden of disease. Here in most of our countries, we now truly talk about a double burden of infectious disease as well as NCDs. And these are problems we face every day. We will continue to need more health workers. And all these things have been brought about by several legacy stories that we have seen. Decades of neglect on health workforce training, deployment, and so on. So there are problems that we need to solve all over the globe, not just in Africa. Now, WHO Afro, working with us, have been analyzing the story of health workforce in our region, and there's now a beautiful report which I advise you to look at. And the report provides a comprehensive assessment of the health workforce crisis in Africa and its implication for our work in the health sector. It introduces important strategies that I would like you to look at. There is the Africa Health Workforce Investment Charter that has been proposed by the regional office, and I think the ministers of health have adopted this, but also there is the Africa Health Workforce Agenda 2026 to 2035. Those are very important statements that we need to be familiar with. These have been advanced by other regional initiatives. For example, the AU, the African Union, has a protocol for free movement of persons. Opportunities are available for mobility of qualified health workers across Africa, promoted by AU. There's also a supporting implementation arrangement. WHO Afro has commissioned us in ACHEST to help them develop a framework for mutual recognition agreement. This is important. When we're training people, can they move around? Can they be accepted? And we have now drafted a framework for movement of our staff, trained staff, across our sub-region, which is complemented by another program on improving the quality of education standards. Very important. These are issues I want you to be familiar with. Now, the objective of my presentation today are really a number of things. First, to build the technical consensus You are all technical people. We need a consensus on how we move with the health workforce agenda, 2026 to 2035. And the focus there is to plan, to train, and retain. I dare say maybe we are training too many people. That's why we have unemployed health workers. We're not planning properly. We're just training and training. And many training schools have opened up, both by government and by the private sector. And we're training too many people that we cannot absorb. And those people, maybe we have not guided them what to do. If we're training, we must also plan how to retain them, how to deploy them. At the moment, it's chaos. And also, we need to identify and shape regional flagship initiatives that I've talked about. We need to promote alignment between national human resource policies, our plans, and our regional agenda. I hope we can galvanize political commitment and financial commitment to invest in education, in employment, in deployment, and retention of our health workers. What worries me most is when the unemployed health workers are poached by people abroad, we start complaining. We start complaining that, oh, why are they taking our health workers? Why not? If you train somebody and they have skills and somebody wants them, don't complain. And I think this is a challenge we should have. You know, we have people who have been trained, not just by the collegiate system he's talking about, but all over. There is a problem. Now, we have some initiative that we want you to look at. The framework for mutual recognition of what we have is available. It's available in WHO, but also online. I think we need to see how to use this framework so that if you have gaps, you can get people from other countries. And also the issue of quality standards of education needs to be emphasized. The findings, some key findings from the analysis done by our colleagues in Afro, let me just highlight a few of them. There is steady progress, definitely. Africa health workforce has continued to grow in measurable quantities. We have better stocks of people, and the health workforce information system has improved. There's also a serious progress in insufficient way of how we do things. Things are working well, but we have really not absorbed our people properly. The challenge has been really, how do we train people that we cannot use? This is a crisis that I think we should work around. But my biggest message to you is a labor market paradox. A paradox of many people trained, and yet we have deficiencies in the field. How could you complain that our health centers are not staffed when we have people who are trained and sitting on the streets? Really, this is not acceptable. So this is the paradox of many, but insufficient numbers in the field. That is really our crisis as Africa. So there are many data online which I could share with you. This is one of them. There's a shortage of about 6 million people by 2030, 27% unemployed or underemployed, and some of them want to go away. 1 in 10 have moved abroad. And if you ask them, 42% really want to go away because they are not being absorbed at home. And that's a crisis we have. More details, 27% of our health workers in 10 countries now are totally unemployed. And at least 55% of the unemployed health workers are nurses and midwives. Can you imagine? Our mothers want to have babies, but we don't have midwives there. This is a serious problem I want you to take home. Now, the mutual recognition agreement is a very nice document which we put together. There are several objectives we want to deal with. First, to harmonize standards of how we train people and so on. And also, we want to facilitate mobility of qualified people across the board. We also want to strengthen regional collaboration through exchange of information, experts, and so on. And importantly, promote quality of patient safety. This is important. and we need to support the health work developments to advance our agenda on UHC and health security. That document talks to that point. Article 5 really pushes the ECSA team to look at this matter seriously, because the matter is coming back to you to operationalize what we are talking about. National competent authorities need to be recognized, and we need to recognize the existing authorities for relevant national standards, accreditation, regulations. All those are important. There are implications for implementation. Certainly from this point, I hope we can talk about mutual recognition. I hope we can talk about quality standards of education across the region. For discussion points in this meeting, I would like to highlight a few things that I think you can talk about. We need to define some of the challenges we are talking about. Africa cannot close its health workforce gap just through training. We talk about, oh, we need more health workers, we need this and that, and the focus is just to go training institutions. We need to do more than just training. There should be a strategic shift in terms of who moves from what point to another point, integrating health workforce strategies that links workforce planning and education and employment. And for me, I want to hear your views about how do we address the balance, the labor force market paradox we face today. How do we address that problem? Problem of having too many but deficient workforce in the field. I think we need to strengthen our national institutions. Particularly, we need health workforce planners. We need good managers. We need policy specialists. Many times when you go to the Ministry of Health, the planners are really general people who can work anywhere in any system, but planning for health work needs requires your understanding of what goes on in the field. What do we need in the field? If you have no idea of what goes on in the field, you will have a problem. So I need to see more planners. We need more better managers of health workforce and policy specialists. These are issues I want you to discuss. Best practices also exist. We need to position the health workforce as a strategic investment. We need to build regional consensus on Africa Health Workforce Agenda, which has been put out by Afro, that focus on planning, proper training, train what we need, don't just train, just because there's pressure. And we should retain them when we employ them. We need to strengthen health workforce planning and labor market intelligence.
2 more minutes, 2 minutes.
Good, I'm almost done. And also share innovative practices across the board. I think we should mobilize domestic and partner investment that focus on these 3 things: plan, train, and retain. For action, there may be some areas that ECSA could deal with. We need to affirm the health workforce agenda properly. We need to request Afro and ECSA to finalize the framework for mutual recognition across all our countries. And maybe recommend that the ministers of health discuss these things further in their meeting, the coming meeting of the ministers of health. They need to talk about, we cannot just train without knowing where these people are going. We cannot just train without retaining them. And if we are not able to employ them, then don't complain when they go abroad. Accept that, we have failed to employ our people, let them be taken away. But I think that is a crisis already. So this is an important agenda I want to bring to your attention. Deal with the paradox of too many people on the streets. They are not employed. Why? Over to you.
Thank you very much, Professor Okello. Colleagues, as you realize, this afternoon, we are really getting areas for discussion. We will need to discuss these issues deeply and come up with proposals, recommendations for action. And I believe as we go for the breakaways, we will meet some of these in small groups. Let's discuss them thoroughly and come up with recommendations. Thank you very much. So let's get the last presentation. But please write your comments and questions. I don't see any movement. The young people who are collecting papers, if you have a question you have written, just raise your hand. Someone will come to you. So Joseph, my namesake, is back to give us a bit more about developing future cleft leaders, I think through fellowships and the rest. You're welcome.
Thank you.
10 minutes or less.
Thank you very much. I'll be speaking about the fellowships and developing future cleft leaders. We've already heard from the previous speakers about what is going on, and I'll go straight to why fellowship matters. And they are not simply training opportunities, they are leadership pipelines. They prepare clinicians to deliver safe, comprehensive cleft care while building the judgment, confidence, and vision needed to lead services in their own context. So from skills transfer to leadership development, the goal is not only to train more providers, but to develop leaders who can train others, improve quality, advance multidisciplinary care, and drive sustainable change across Africa. So some of our partners in fellowships are here, including COSEXA, CANEXA, Kids Operating Room, University of Nairobi, the Global Health Equity University. We also have PATA with the Vanderbilt University and ENAM. So with Kids OR, we are currently providing pediatric surgery. Earlier I had mentioned that we've built over 50 pediatric theaters. They need professionals who would be able to provide care for our pediatric patients, and therefore together with Kids OR and COSEXA, we are training pediatric surgeons with COSEXA, again for plastic surgeons, CANEXA for pediatric anesthesiologists, and then PATA as well for pediatric anesthesiologists, the UGHE for general surgeons, and then ENAM for speech therapists. So these are just not numbers of the many people or many professionals that we've trained in the different universities or colleges with WACS, West Africa College of Surgeons, post-fellowship in cleft care, again for plastic surgery, pediatric surgery, and pediatric anesthesia. But these are also people that need to be absorbed into the health workforce so that they can continue to provide care for the patients that they are seeing. So again, these are still opportunities where the countries represented can also get access to these trainings and continue to build the healthcare workforce. So, and through these trainings as well, we are also building the next generation of leaders and the next generation of healthcare workers. So what should the strong fellowships produce? So a successful fellowship should produce professionals who can, one, deliver safe, high-quality care, lead multidisciplinary teams, mentor the next generation of leaders, then use data to improve outcomes and advocate for equitable access to care. So with Smile Train, again, once we train these healthcare workers, we've started a forum that we call the Smile Train Africa Alumni Network, where they are able to come together, share experiences, and also come to forums like this and share what has happened in the different countries, as well as the PASHEF, which I had spoken about before, where we are trying to advocate for inclusion in policy matters. So at with PASHEF. So we are doing, this is an Africa-led platform that is influencing surgical reform to formalize participation in national plans. Then we also have a network of healthcare workers from across the globe that also we are also sharing with the African counterparts to ensure that we grow together. Then we have stronger united voice in global surgery governance while giving recognition and visibility to sustain engagement. And still on this platform, we are able to identify champions by speciality and region and match diaspora skills to real needs. So again, through this same PASHEF, we are trying to push the NSOP's agenda. And here we want to elevate care within the NSOPs. We want to influence health financing and UHC inclusion. We want to build advocacy champions and align surgical workforce strategies. Again, through the PASHEF and University of Global Health Equity, we have this policy to practice fellowship where we are supporting Smile Train. And the essence is to advance surgical care in Africa by converting policy to practical implementation projects. So we are empowering policymakers, technocrats, and healthcare professionals to move from theory to practice in implementing surgical healthcare solutions. So here are some of the fellows for policy to practice fellowship at the UGHE. They come from those countries that have been indicated there in West Africa, East Africa, Central Africa, and Southern Africa. And this is where most of the people who are represented at PASHEF, or the countries that are represented, are here. So I know if your country is not represented, we need to work together. We need to collaborate so that we push the advocacy and policy for healthcare workers and the surgeries. As my parting shot, the future of cleft care will not be secured by surgeries alone. It will be secured by the leaders who intentionally prepare today. Let us invest in fellowships that build capacity, strengthen systems, and leave behind a legacy of confident, compassionate leaders. Thank you very much.
Thank you very much, Joseph. Thank you so much. And I think those are the 4 presentations that had stayed. Okay. I just hope that all the presentations are being uploaded to this website. Is it the website or conference site? So that, because this is very good information, you can see, it will help us to make critical decisions at home, and even for the discussions that we're going to. So endeavor to reach there. Maybe Dr. Maringa will provide more information on that, how to reach, to get these uploaded papers and where they are. Okay, so now we want to answer some questions, receive your comments, your advice, your criticisms, and everything. Raise your paper if you still have it there. Next time we shall upgrade to a soft way of sending these comments. There are many. There is Slido, there is what. So you don't need paper, you just send it to some source. The IT people here should sort that out. Okay, no more papers at the back. Professor has one, yeah. So you can start.
I have a very interesting question here. Let me read it, and hopefully.
I will add this one, but don't say that was from me.
how do we ensure eco standards in ECSA health community, especially with unregistered private sector mushrooming growth in enrollment. This is likely to affect our mutual recognition of health workforce. How do we ensure? I think I can pose this question. I would like to pose this question to regulators, really, because the private sector is using training as a business. You know, if you can afford, we will give you a degree in nursing. If you can afford, we give you a degree in medicine, and so on and so forth. And there's so many private sector training programs that have mushroomed. They use the word mushrooming. I think it goes back to regulation. If we cannot regulate what's happening in the country, we are going to have a crisis. In my view, we should train what we need. And training does not have to be done by government only. Training can be done by the private sector, but we should regulate what is going on, including standards. In the country I know best, if you go to their classroom, nursing program, the classroom is bigger than this room, and they have thousands of students being trained on dolls, you know, simulators. And when they graduate, they have not seen blood before. It's a mess. And really, this is a problem. You may be underrating it, but there is a crisis already happening at our doorsteps. The private sector just wants, their interest is not to fill our health security agenda, UHC, and so on. They just want money from these people. Once the parents can afford, you will get a certificate. Certificate in the street that you are a nurse, that you are a doctor, and so on. And it's a crisis already. You land in a hospital, in some of the private hospitals, and you're being treated by somebody who, even you wonder if they know any anatomy at all. You know, they start putting on a drip. Instead of this way, they put it that way. You know, they're putting on a drip on a dehydrated child. Say, what's going on? So the issue of mutual recognition must address all these issues. First, we need to be strong as national regulators. Our policies should be correct. At the moment, I'm sorry, we're not giving any guidance at all. Things are just happening. Another question. I don't know whether this is from our moderator or from somebody. Is xenophobia a threat to mutual recognition of our qualifications? I don't know if I can answer this, but certainly it's happening in our neighborhood already. This term, xenophobia, is a very strong term, but it's happening. It's happening already, that even qualified doctors, nurses, are being told to go back to their countries, even when they're doing a good job. So this mutual recognition within our states is extremely important. It should sort out that problem. That once you accept somebody to work in your place, they get proper papers, and you don't wake up one day and chase them away. How can ministers of health collaborate to enforce demand-driven enrollment quotas rather than continuing unconstituted? And same story, I think it's the whole issue of policy, proper policy, regulation, ministers of health enforcing some kind of norms of how to do things. I think they should start intruding into what the private sector is doing. You're training people to treat us. You should follow the standards that we set. If you don't, you should not be allowed to train. I think this can be enforced. So it's a good feedback, but really, when we make our recommendations at the end of this meeting, we should deal with this problem. We are having problems with too many private sector training people, and we don't know what they're doing in their training. But also, even the ones trained by government, they are not all being absorbed. If you train people whom you cannot deploy, then we have a problem. So really, I want you to take it serious. Let's have a strong recommendation around this matter and then present it to our ministers of health and let them chew it. This is a policy issue and it's relevant for our discussion, I think. Thank you very much.
Thank you very much, Dr. Kelo. I think Dr. Innocent, you have a question?
So since my colleague stood here, I think I should also come back. And this question is addressed to Dr. Kiza, but many people commonly refer to me by that name. So, but just for correction,
Dr. Kiza.
I am not in the basement. This is Dr. Besije Innocent speaking. Yeah. So the question goes, from the mentioned courses, you did not mention anything to do with rehabilitation professionals. So the question is, are there plans to also interest on these cadres as well? Like I mentioned, one of the asks we are making, and our vision is to expand collegiate training to other health professional cadres. And so every specialty which is not yet included among the 11 colleges is welcome. But the way we do things is that if you know any group, for example, of the rehabilitation professionals, inform them that there is an opportunity to start the college. Then they will approach the ECSA College of Health Sciences, which I mentioned their headquarters being in Arusha, and then they will be taken through the application process on what is required, and then once the process is completed, they will be admitted. So the answer to the question is not only to rehabilitation professionals, but every professional which is not yet represented among the colleges I projected is welcome. Thank you so much.
Thank you very much, Dr. Innocent. Okay, is there anyone with the last comment? I see only one. You can have the mic. Then we close because we are operating under borrowed time.
No, the issue of, I think Dr. Keller has really articulated a very valid, a crisis that is happening that I think probably ECSA, the ESC, and SADC should take up, because we have frameworks for regulation by the ESC. But what is happening in terms of the quality of medical education is really worrisome. And this lack of mutual recognition agreements is real. When we had Marburg, I will not tell you the country where it was, we deployed infection prevention and control nurses from another place. And they were ready to go. But they couldn't be allowed to practice for almost 2 weeks. Some of them had to get out of the country. So it affects outbreak response in real terms. So I really think that this should go as a resolution, it should go as a recommendation. And the model that is really used by the colleges for accreditation is very good. And I think we can have sites that can be accredited, and then we have ECSA, ESC, SADC drive the mutual recognition agreement, because they will help. If I deploy people as a surge team to Eswatini and they can't work for 2 weeks, and the outbreak is killing people, and they are very good, we are shooting ourselves in the foot.
Good. I think that's the summary We would like to close this session now here. We have borrowed about an hour or so from the afternoon session. Please join me to appreciate the presenters. You can take your seats. Asante sana. Thank you so much. And before I hand over to my sister, Dr. Malinga, and my boss, Dr. Subusi Siso, to guide us. It's already 4 p.m. I hope we can have some more engagement, but the two will give us the direction. One of them should be able to guide us. But before they come, or as they come, please, can I request that you appreciate the moderator? Thank you. Thank you so much for the day. The mic is here. Thank you.
Good afternoon, distinguished delegates. It's been a very information-heavy afternoon. However, we still have the parallel sessions. And I also know that we want to continue the discussions, especially of what has been started here. So I think we can agree that the parallel sessions, they will continue. We said this room is ballroom 1. And on my immediate right, it's ballroom 2. On my far right, it's ballroom 3. And downstairs, ground floor, we have ballroom 4. And that is aligning with the different breakaway or parallel sessions that are already outlined. So may I allow the delegates to move to those different ballrooms. Thank you. We also have a lost and found card from Hilton. If you are missing your card, the key card, please go to the registration desk. Okay. Yeah. So let's see. It's an hour.
Yes.
Oh, okay, maybe just as a quick reminder, for room 1 here, which is this room, we'll be talking about health security. Then for 2, it's digital health. Then for 3, the other one on the far right, it's on demographic dividends, youth and nutrition. Then the one downstairs by the other exhibition area, it's on human resources for health.
All right, for those who remain for health security, we kindly request you to come forward. And for others, please, you can go quietly so that we save time. So we call upon Bongani Dube to please come forward. Priska, Ali Hussein, Rifat Hussein. For those who are not here, please, we want to start the session. Where is Chris? Which email do you have?
Maybe we can use flash drive.
They have already. Seven. 17.
You are the ones that sought with him in the presentation.
I don't know. But it's okay. That's what I mean. They don't have presentation here.
Yes, who has planned for